Hi everyone. I'm here with Dr. Donna Vine, which is a great pioneer in the research on PCOS, and who's here to talk to us about a little bit about PCOS and the work that her lab does. So, how are you doing, Dr. Vine, today?
Good. How are you?
I'm doing great, thank you. So just to start this conversation, we were wondering if you could talk to us a little bit about what is PCOS, just in general, what are the health risks, what are the symptoms in general?
Yeah, so PCOS actually impacts approximately 10 to 15% of females worldwide, and those individuals with PCOS present with many different types of symptoms. But the symptoms may be irregular menstrual cycles, so not having a menstrual cycle um, in a every 30 days. They might have one every 4 months, or they might not have one for 12 months. And then there's associated infertility and anovulation. And then there's hirsutism or excess male hormone testosterone, which is basically male pattern hair growth on different parts of the body where you wouldn't normally expect to see excess hair growth on a young woman, which can be very disturbing, as you can imagine. So, on the back, on the chest, the arms and legs, on the face, and that can be very thick and coarse hair, and so that can be very difficult to manage. And then there's associated body image with that. And then, there could be heavy menstrual bleeding as well, which is very common. It's not a symptom per se, but we find it's very common in those with PCOS. And then those are some of the key features. And then there could also be cystic, or what we call polyfollicular ovaries, where the follicles in the ovary have arrested growth and fill with fluid, and it looks like cysts, but they're just follicles with arrested development. And so when we diagnose PCOS, it's based on 2 out of 3 of the following. So either uh, polyfollicular ovaries, menstrual and ovulatory dysfunction, and then what we call hyperandrogenism or excess testosterone. And that excess testosterone we measure as free testosterone in the circulation. So that's the diagnosis. But the other symptoms could also include like prediabetes, overweight, obesity is very common. And with the metabolic milieu of PCOS, it exacerbates some of these cardiometabolic risk factors and symptoms. So that's a little bit of background on how it's diagnosed. And we also have to rule out other endocrine disorders, which is very, very important. And we've just established a pathway to care for patients with PCOS for the patients themselves and also for physicians, so specialists, family physicians, OB-GYN, endocrinology, and an algorithm for them to follow to help them with diagnosis and management, because it really requires a multidisciplinary team because of the associated comorbidities and just to manage the symptoms of PCOS.
I see. So I can see that it's a very complex disease that involves a lot of systems. Could you tell us a little bit about the more deep mechanisms behind the disease just to help us understand? Because there's a broad range of symptoms, but what are the mechanisms that kind of link these symptoms together?
Yeah, so it's complex and it's very heterogeneous. There's not one cause of PCOS. In genetic studies, there's multiple genes involved. So, from steroid metabolism to insulin to body weight management to the feeding center to insulin genes. So, it covers a whole lot of different genes, and those genes can be regulated epigenetically. They could be familial, so carried in families. There's a high incidence of those with PCOS. Their family members may have PCOS, so their mother, grandmother, sisters, and also it runs in families with the male sibling as well. The male sibling might present with metabolic syndrome and potentially infertility or other related comorbidities with the metabolic syndrome. So it's has a genetic origin, And there could also be point mutations in some genes. So, for in the ovary, for example, do over produce testosterone, leading to a specific phenotype of PCOS. And we have different phenotypes. So, some women will present with menstrual irregularity, hyperandrogenism, and polyfollicular ovaries, and others may only present with one or two of those things, or less severe of those things, but they have to have 2 out of 3 of those symptoms to be diagnosed. So there's a lot of heterogeneity, and it's thought to start very early in childhood if there is a genetic predisposition. And there's been studies that show very early adiposity and overweight in young girls, and this is linked to later onset of PCOS. So, very much that genetic basis, but it could also be onset by an obesogenic environment where you have excess kilocalorie intake beyond your energy requirements. And then that leads to some overweight obesity, then leptin resistance, insulin resistance, and then you get this vicious cycle that then impacts, the ovulatory function, the hypothalamic pituitary ovarian axis. And then you get all sorts of other comorbidities because of that metabolic milieu related to insulin resistance, high androgens, as well as the obesity in these individuals. So it's, a melting pot of different phenomenons and metabolic causes, and it's very dependent on the individual. But there could also be these SNPs or 1-point genetic mutations that, like I said, that really cause PCOS in those individuals.
Okay. And based on these very different mechanisms, point mutations, genetics, the hypothalamus, the HPA axis,
Mhm.
I was wondering, does your lab, I was wondering if you could summarize the work that your lab has done to address these mechanisms in order to treat potentially PCOS?
Yeah, so we have an animal model of PCOS. It's an interesting model because it has a leptin resistance. So it has a defect in the leptin gene. It's not a full defect, it's only a partial defect. And it actually is very similar to women with PCOS. So it presents with anovulation, irregular cycles. It develops increased body weight very early in life, and also has cystic ovaries. So it's really quite interesting. So we use that model to look at mechanisms. We've been looking at a lot of mechanisms of how androgens themselves impair insulin resistance, impact the intestine and the liver in terms of lipid metabolism, and also looking at different interventions with metformin, with fish oil, and other drugs to see how those metabolic pathways are regulated by those different drugs. So that's how we use the model. And then we do clinical studies. We've been focusing on cardiometabolic risks. So we've done studies with metformin and fish oil to reduce cardiometabolic risk factors and very early cardiovascular disease. Some of our studies show that young adolescents and young women have very early vascular disease, so increased carotid intramedullary thickness, carotid plaque, and early cardiac dysfunction where they have increased left ventricular hypertrophy. So their heart is already expanded and impaired diastolic and systolic function. And we're looking at that in the animal model as well to see if we can correct that with different medications and even just diet, exercise, and lifestyle intervention.
Okay, I see. This is very interesting. And I was also wondering because you mentioned that there's many different phenotypes according to the mechanism through which this PCOS occurs. And do the heterogeneity of the phenotypes cause a challenge in diagnosis and treatment of PCOS?
Not so much of a challenge. I think it's just you have to be aware as a healthcare provider and as a researcher that there are different phenotypes. So you might get a phenotype that's more resistant. So to intervention, for example, or presents with more severe symptoms. So the classic phenotype of PCOS is that they have all three symptoms or presentations, those polyfollicular ovaries, the hyperandrogenism, and the menstrual dysfunction. And that actual phenotype, together with the phenotype of hyperandrogenism and menstrual dysfunction, they seem to have the exacerbated development of diabetes, cardiovascular risk, and they also have more severe symptoms related to those criteria. So we're learning more about that. And this is where I think what's unique about PCOS compared to age BMI matched controls is that what's the difference? It's the androgens, it's the elevated testosterone, which we know can exacerbate insulin resistance, which can disrupt the ovary and normal feedback to the hypothalamus to regulate normal ovarian hormones, and feedback from the hypothalamus like follicle stimulating hormone and luteinizing hormone. And then that can disrupt further the ovulatory cycle. And androgens themselves can have effects on the heart, the blood vessels, the intestine, the liver, and that's what we're learning in our studies. So we've learned that testosterone can actually exacerbate lipid production in the intestine and the liver. It can increase triglyceride production in addition to the insulin resistance. So it exacerbates these conditions. And even testosterone itself is what we call an orexigenic hormone. It's basically a hormone that's designed to increase our food intake, our growth, our storage of nutrients. And that's what we see in women with PCOS. So sometimes they have, high food-seeking behavior as well, because their androgens are elevated. They're always feeling hungry, yet they don't really need the kilocalorie intake, but their brain is tricking them into that they're hungry. And if they have insulin resistance with that excess testosterone, it can exacerbate that. And then you've got that cycle of food-seeking behavior that we also see with eating disorders associated with PCOS. So it's very multifactorial across, like you said, many different systems.
Okay, I see. And what are some common diagnoses that, like, when in a patient that inherently has PCOS, what are some common misdiagnoses that are made other than PCOS in female patients?
A misdiagnosis. I think one of the major problems that's happened in the past, which is why we developed the pathway, we found that 90% of, nearly 90% of patients took longer than 2 years to get diagnosis. The average age was 24. So it just takes a long time. And that's a long time in the period of a young woman when they're studying, working, establishing themselves in their early career or early motherhood. And or both. So it's a really critical window. So one of the challenges is actually getting an early, accurate diagnosis to then manage that disease for these women effectively. And it requires a multidisciplinary team, and for physicians and the patient to know that you can't solve everything in one appointment. It's going to take time, and it will take time to manage potentially each symptom, trying different medications, but it also depends on the patient, what their major symptoms are and what they are most worried about, what's most critical to them. It could be, irregular periods, it could be their fertility, it could be their facial hair, or a combination of. So actually the accurate diagnosis as early as possible in a young woman or a female or individual with PCOS is probably the most important, and ruling out any other endocrine disorders, obviously.
Hey, that's interesting. Yeah, so to go back to what you said earlier, that the manifestations, physical manifestations of PCOS can sometimes lead to not just physical, like appearance-wise, but they can lead to eating disorders because of the hunger regulation as well as body image issues. And these could lead to mental health conditions. And I was wondering if your research had actually addressed this connection between PCOS and mental health.
Yeah, so we did a large epidemiological study that was published earlier last year, and that showed that eating disorders are around 30% higher in those with PCOS. So that was a large epidemiological study in Alberta, Canada. And we've also been doing surveys on eating disorders in those with PCOS and then healthy controls or healthy BMI weight match controls. And we see, a significant increase, 2 to 3-fold increase in eating disorders like bulimia nervosa, purging disorders, nighttime eating disorders, and binge eating disorders. And we believe it's related to the insulin resistance and the androgens, like I mentioned before. They promote food seeking behavior and they cause less satiety. So you're always feeling hungry. And also, they promote weight gain. And so then you have an individual who's battling with their eating behaviors or disordered eating, and they might think it's normal, not realizing. And then they're also battling with their body weight, potentially their body hair. And so you get this anxiety, depression, and it's, like I said before, a very vicious cycle. So this is where awareness of all of the mental health issues and eating disorders, which are a mental health, really need to be screened for and addressed by the healthcare provider. And this is important because it means that that patient might need referral to a mental health, uh, allied health care worker to address, underlying causes of an eating disorder. And this is where we have to bring in cultural sensitivity, trauma-informed care, to make sure that we're really helping that patient work through any of those mental health disorders that may be contributing to their PCOS phenotype. And then if they've got this concern, this is where, the mental health concerns come in. So addressing all of these things becomes really important for addressing what's important for that patient and taking a step back with the patient and really trying to investigate what are their different symptoms and screening for different mental health and eating disorders, because that could be contributing to their overall stress, cortisol levels and weight gain, contributing to ovulatory dysfunction because of their body weight, insulin, and androgen levels. So everything needs to be addressed in a holistic manner to really help these women.
I see. Yeah, it's very important that they get the help they need in every
Yes.
single aspect of the disease, indeed.
Yeah.
And if that's okay with you, I'm just going to like ask one last question. Was there anything else you wanted to talk about before I conclude?
Sure. I mean, as young healthcare professionals in training, I think it's great you're learning about PCOS. We know that in many different medical programs, they might have 3 or 4 minutes of PCOS in
Yes.
their OB-GYN module of
Yeah.
reproductive health. So the more women and females and individuals can learn about PCOS and raise awareness is really important because it's so common and it's really understudied, under researched, just like general women's health you know, but I think PCOS is a significant part of that and impacts women across their lifespan. It's not just in childhood, adolescence, and in their reproductive years. We know it impacts women into their menopause and postmenopausal years. In some ways, could be positive because we know testosterone helps bone growth and muscle development. So it could be a positive thing as well in individuals. But there's also a lifelong impact with, increased comorbidities like cardiovascular disease, diabetes, obesity. There could also be increased risk of reproductive cancers in the uterus and ovary. So that it is a lifelong disease. So as a healthcare professional, you will be seeing these women across your practice and across their lifespan. And you might have one patient that's with you for 30 years in your practice. And so you'll be seeing them go through their life stages dealing with PCOS and how it changes over the lifespan.
Yes, that's true. We don't often think about the long-term impact of PCOS in the lifetime, so definitely that's something to consider. Yeah.
Yes.
Well, thank you so much, Dr. Vine, for sharing everything with us and for accepting to be part of this episode. And thank you.
Great.